You can spend hours in a quiet library memorizing brain lobes from a textbook. But when you step into the ICU and those monitor alarms start blaring, that slow academic study doesn't help you save a crashing patient. I've spent 20 years at the bedside, and I've learned that surviving those high-stakes moments requires a different way of thinking. In this video, we're merging AI-driven data analysis with real-world clinical experience to translate dense textbook anatomy into actionable bedside reality. This flowchart shows the body's chain of command, starting at the absolute top with the central nervous system. You can think of the CNS as the core nervous system, or the CEO. It consists exclusively of the brain and the spinal cord, and it is where every single executive decision in the human body is made. But a CEO needs a staff to carry out those decisions. That's the peripheral nervous system, or the performs nervous system. The chart expands here to show these nerves branching out to every muscle and organ acting as the support team. They execute both the somatic, voluntary movements like walking, and the autonomic, automatic processes like your heart rate and digestion. When you understand this exact chain of command, you stop guessing. You can systematically assess if the body's CEO is awake, functioning, or actively failing. A neurological assessment is your real-time bedside window into the brain's status, and the absolute first priority before you check a pupil or ask a patient to squeeze your hand is establishing their level of consciousness, or LOC. We measure this using the Glasgow Coma Scale, testing eye-opening, verbal response, and motor response. If that combined score drops to 8 or below, the patient can no longer protect their own airway. You must prepare to intubate immediately. Once the airway is secure, we evaluate the 12 cranial nerves and use PERLA to check the pupil's reaction to light. These tests confirm that sensory and motor signals are successfully traveling to and from the brainstem without interruption. When those signals get blocked, it's often a structural crisis. Swelling or bleeding creates increased intracranial pressure, or ICP. The brain is trapped inside a rigid skull. So as pressure builds, the earliest warning signs are an altered level of consciousness and sudden vomiting without any preceding nausea. If you see those cues, you have to intervene mechanically. You elevate the head of the bed to exactly 30 degrees to promote venous blood drainage, and you strictly minimize airway suctioning, which causes dangerous pressure spikes inside the skull. Then you intervene pharmacologically. We use osmotic diuretics like mannitol, which pulls that excess dangerous fluid out of the swollen brain tissue and into the bloodstream to be excreted. Detecting early shifts in consciousness is the only reliable way to trigger these mechanical and pharmacological interventions before the pressure forces the brainstem downward into a fatal, irreversible herniation. Beyond physical pressure, the command center can also fall victim to electrical instability. A seizure is a massive, sudden disruption of motor output that instantly strips away a patient's ability to protect themselves. During an active seizure, your absolute priority is physical safety and airway protection. You roll them onto their side to prevent aspiration, you pad the surrounding area, and you strictly avoid placing any objects in their mouth. This gauge represents the strict therapeutic window for phenytoin. Blood levels must stay exactly between 10 and 20. Overgrowth of gums is expected, but if that needle swings over 20, the patient is toxic. Immediately watch for ataxia and slurred speech. Electrical misfires also happen further down the chain of command. For patients with a spinal cord injury at the T6 level or higher, there is a severe, highly tested emergency known as autonomic dysreflexia. A blocked catheter or a restrictive piece of clothing acts as a noxious stimulus, triggering a massive miscommunication in the lower nervous system. The patient presents with a pounding headache and life-threatening hypertension. Your immediate two-step intervention is to sit the patient straight up to 90 degrees to drop their blood pressure, and then systematically find and remove that stimulus. In any acute neurocrisis, whether you are dealing with an electrical storm in the brain or an autonomic misfire in the spine, immediate positional changes to protect the airway or lower blood pressure are always your first line of defense. Not all neurological conditions happen in a split second. In chronic neurodegenerative diseases, the communication pathways between the central and peripheral nervous systems slowly degrade over years, requiring long-term pharmacological support. In Parkinson's disease, a severe deficit of dopamine starves the brain. Without that crucial neurotransmitter, the body cannot initiate smooth motion, resulting in rigid, slow, and shaky motor output. We replace that missing chemical using a combination of levodopa and carbidopa. But there is a strict clinical rule regarding this drug. Patients must avoid high-protein meals because dietary protein directly blocks the absorption of these medications. Further down the line, myasthenia gravis causes a failure in the peripheral nervous system. A lack of acetylcholine causes severe progressive muscle weakness. The body effectively enters a dangerously dry state, lacking the neurotransmitter lubrication it needs to function. This scale illustrates the delicate balance required to treat it. If the patient is too dry, they enter a myasthenic crisis and require neostigmine to boost secretions and mobility. But if they get too much medication, they flip into a cholinergic crisis, becoming dangerously wet with excessive secretions, which requires atropine as an antidote to dry them back out. Managing these chronic neurodegenerative conditions isn't about finding a cure. It's an ongoing, precise pharmacological balancing act to keep patients functional and prevent sudden physiological crashes. The logic of the nervous system is strict. The central nervous system issues the commands. The peripheral nervous system executes them, and your clinical assessment evaluates the integrity of that connection. When that connection fails, your actions have to be immediate. A GCS under 8 means intubate. During a seizure, airway protection is your only priority. And for spikes in intracranial pressure or autonomic dysreflexia, rapid positional adjustments save lives. Hey, thanks for watching my YouTube channel. Don't forget to like and subscribe and leave a comment. Let me know what topics you want to see more of and how I can help you become the super nurse you were born to be. I hope to see you here again real soon.